continuous capture, so it's kind of confusing.
Mm-hmm.
So what we'll do is we're going to hit the stress button. And then instead of the default 2x4, you're going to hit template. And then we're going to choose our phonological 4x4. Now, we see the pattern. We're going to start in our 4-chamber for our baseline images. Baseline is when they haven't been given any medication yet. No dobutamine has been started. So these are your resting pictures. So you're going to push begin, and we'll start in our apicals. Again, set the depth appropriately first here, and you'll be on axis for everything for your long and your short. That's why it's nice to start in apicals.
Mm-hmm. So we want to have we want to cut off.
Yes, just your LV is all we care about. So you can cut off those atria a little. I'm going to overgain a little bit if we need to. There we go.
Okay.
And then it's going to be the same way. You'll hit image store.
Oh, okay. Image store.
And then what you'll do is if you want to keep it, you're going to push select or image store. If you don't like it, you hit freeze to remove it. Okay, and then you'll go to your 2. Tells you right over here what you need. And you'll do the same thing, image store. And then if you like it, keep it. If not, hit freeze and it'll go away. And then parasternal long. Oh, check your notch. Yep. And then again, since you set your depth in your apicals, you're good for parasternals. Nothing will be cut off here. Good, and then short. Such a pretty heart.
I know. Her flex is so nice too.
Everything is so pretty. Okay, so now what it does for this machine specifically is you're live on this side because it wants you to go into acquiring low dose. So that's why you're seeing short because your probe's down, you're live. Over here, it's pulling that clip that you acquired of your baseline 4-chamber. It now wants you to get your low dose 4-chamber. So what would have happened here is you wait, the nurse has started the dobutamine drip, it's infusing. We're watching our heart rate to see if it comes up just a little bit. We don't want it to be the same as rest. It should uptick, but typically it's still under 100. It just depends on the protocol and how rapidly they're infusing the dobutamine. You have a little bit of time when they're doing a dobutamine because they're not coming off a treadmill and you have 60 seconds. They've got medication keeping their heart rate up, but your patients will feel like crap. Their heart's racing, they're laying flat, they normally get headaches, they get nauseous, some actually even throw up. So you do still have that urgency of trying to move as quickly as you can, but you have a little bit of a cushion where you don't have that with someone that's on a treadmill. So we'll go ahead and acquire our low dose here. We'll pretend her heart rate ticked up a little bit.
And select the same? Or
Yep, same way. Select if you want to keep it and freeze to cancel. And it will almost always have the instructions here if you're ever like, wait, what do I do now? That's the nice thing about the GE. And then we'll get a 2.
It's like hard to get the RV.
I know, it's this tiny movement.
I'm just gonna take that.
Yeah, yep. And then we'll go to long. Nice. And then short. Okay. Now it's putting you into the peak. So what we do here is we're waiting for that patient to get to their target heart rate. A lot of times dobutamine on some people works really well and we can get their heart rate there once they hit that max dose. But we're seeing more and more that people have to have atropine to get them to that target heart rate. Most of the time a physician should be in the room because if you give atropine, they have to tell you what dose. They have to be there to monitor the patient. It's a serious drug. So we try to avoid having to give it, but if they aren't making target and we've maxed out on dobutamine, they will go ahead and push atropine. So it's nice if the physician's in the room. The first job I had, they would be in the room and they'd say, okay, grab your mids, grab your low dose, grab this now. Oh, I like that picture. And they'd help you through it. The job I'm at now, they just are like, I'm in the room next door, come get me. So you're kind of on your own, but it's you and the nurse. And normally things go smoothly, but if they want something special for a protocol, some will rapidly infuse dobutamine. They increase the dose every 2 minutes. Some do it every 3 minutes. I've had just so many different things from physicians where they want a baseline, a low, a mid, a peak, and recovery. There's 5 stages, not 4. I've had it where they don't want recovery. They just want baseline, low, peak, and recovery. There's just so many variations of a dobutamine. That's why it's like I can't teach you exactly how to do it, because you're going to have to learn it how your physicians want it, what your indication is. Tapers how you do an exam as well. So what pathology is there? Are they looking for ischemia? Then you're checking your LV. Are they looking at aortic stenosis? Then you need Doppler too. Whole different ballgame. We'll talk about that at the end here as well though. But so for these peak ones, most machines now are set up where when you push image store, it does continuous capture. The GE guy dropped this machine off. I didn't have any say in how it's programmed. So actually when you hit acquire, it's going to be the same thing like it was for your low and your baseline. But again, normally there's urgency to get these pictures, and having to acquire and then review and pick one and then go back, like that just takes extra time and the patient's feeling like crap. So a lot of places it's continuous capture. But on this it is not. Okay. Good. Okay. Now, the next stage that we are asking for is recovery. So with recovery, you're waiting for they've stopped the dobutamine, we're waiting for their heart rate to come down below 100 or as close to their resting as possible. Normally you're sitting here just waiting for quite a while. Sometimes, especially if you give atropine, I feel like it takes way longer once they reverse it for that patient's heart rate to come back down. The dobutamine still can be going through their system, so it's a waiting game. Dobutamines are kind of long. But once she's down under 100, then you take those recovery images. And it'll be the same way that you guys have been doing it.
Wow.
Nice.
Nice.
You can see, look, they're perfectly on axis,
Yeah.
just like it was at
It
rest.
has to be the last one.
Yes. Helps when you have an easy subject.
Ah, the aortic valve.
I know, right? The things we get excited about as sonographers. Now it'll say, do you want to perform analysis? This, I've never seen a machine do this because most physicians read off the PACS system. But I guess maybe it's if you wanted to prelim report on it. So just hit yes. I'll just show you what this machine will do. But in each stage, you can diagnose or you can input wall motion. So like if you bring your cursor over here, you could hover over and say, okay, at peak, I noticed that this mid-anterolateral wall is akinetic. That's kind of cool. But honestly, we don't do anything like this. I've never seen this before on a machine. It's just a cool feature of the GE. But when you hit perform analysis, it'll at least give you all of these side by side. So this is your baseline, your low, your peak, and your recovery, all of your 4 chambers. You go to the next page, it's all your 2 from each stage. And what the physician's looking for in a regular dobutamine when they're looking at ischemia is they're seeing is that LV contracting more. Because remember, dobutamine will also just make the heart rate go faster, but it increases contractility. So you'll see that the strength of that contraction, you're seeing that muscle will squeeze a lot harder as well as faster. If the heart's normal. If there's a blockage, then you notice it's not moving as well. So you can look through each view. And then again, we'll go to review here, and we should have somewhere, we won't have a continuous capture because we didn't do one. But if we did, we would delete that. But this is, and we'll just end it.
Oh, just end.
Yep.